Hi guys, welcome to another lecture, and today we'll be discussing something about spectrum of E. coli diarrhea in pediatric population. So the spectrum of E. coli infection in pediatric population is very important, and there are technically 5 types of E. coli. So EHEC, enterohemorrhagic, enteropathogenic E. coli, enterotoxigenic E. coli, enteroinvasive E. coli, and aggregative E. coli. Okay, so these are the 5 E. coli that usually cause diarrhea in pediatric population, and they have their own set of clinical features. Like this enterohemorrhagic E. coli, it leads to hemorrhagic colitis. There is colitis, hemorrhagic colitis, and HUS, hemolytic uremic syndrome. HUS is specifically caused by O157H7 variant, and this is actually sorbitol non-fermenting variant of E. coli. So this is the thing that is caused, and it is usually bloody, non-bloody. Both diarrhea is possible. The pathogen over here, or the issue over here, is the Shiga toxin. Shiga toxin, and the Shiga toxin leads to coagulopathy, large bowel involvement, colitis. So the Shiga toxin is the pathogenic agent in enterohemorrhagic E. coli. In enteropathogenic E. coli, it leads to acute and chronic, epidemic, and endemic diarrhea in infants. So most common cause of infective bacterial diarrhea in infants is EPEC. Okay, most common infective diarrhea in infants is rotaviral, but for bacteria the most common is EPEC, and this bacteria actually causes small bowel adherence and effacement. So this is the pathogenesis in EPEC. Now for enterotoxin, like the enterotoxinogenic E. coli, it is the most common cause of traveler's diarrhea in all ages. Traveler's diarrhea. Okay, traveler's diarrhea, it is the most common cause in all age groups. Traveler's diarrhea is caused by ETEC, and there is presence of an enterotoxin that can be heat labile, heat stable, both, but the enterotoxin is there which causes all the issues. Now enteroinvasive, usually there is presence of diarrhea with fever in all age group. Okay, no specific infants or young children, in all age group, and there may be bloody or non-bloody diarrhea. Okay, dysentery also might be caused, and this occurs due to mucosal invasion of the. It causes the mucosal invasion of the cells, enteric cells. Enteroaggregative is technically similar to enteropathogenic, and it also leads to similar to EPC. Okay, everything is similar to EPC, and there is also EPEC plus there is presence of enterotoxin. Okay, so EPEC with enterotoxin leads to EAEC, which is similar. It is a combination of EPEC and EIEC. Okay, so that is the issue. Now, how to treat the patient? Treatment, very important treatment. So treatment is important. Why? Because you have to understand one thing, that here augmentin like co-amoxiclav and ampicillin, they are inherently useless for E. coli. Okay, so they are technically useless for E. coli for all patients. Okay, so once you have done this, the first line drug is either third gen cephalosporin or plus aminoglycoside. Okay, so this is the first line. Now if these drugs are resistant, it is known as MDR E. coli, and the drug of choice for MDR E. coli is meropenem. Okay. Meropenem is the drug of choice for MDR E. coli, where third generation cephalosporin and aminoglycoside do not work. Now, whenever there is an extended spectrum or carbapenem is presence, then even meropenem is not working. Then the drug of choice is either polymyxin B or colistin. Okay, that's all. This is all you can do for a patient. For enterohemorrhagic, you can go for eculizumab when you have HUS, eculizumab plasma exchange. You can go for FFP therapy. You can give mycophenolate, mofetil. So all these drugs are effective. But this is the basic about the spectrum of diarrheal disease in E. coli. I hope you like this video, and I will see you in the next one.